Hello, and welcome to my presentation of supporting veterans presenting with dementia, a major neurocognitive disorder. My name is Amy Blackman. This is for my class Diagnosis in Psychopathology in the fall of 2024. Our teaching points for today are a mini. I'm going to talk about basic information regarding dementia, predisposing social and cultural factors, DSM-5-TR diagnostic criteria, differential diagnosis of dementia, etiology of dementia, briefly talk about the stages of dementia and the Global Deterioration Scale for assessment of primary degenerative dementia, which is the GDS. This has been commonly used for these purposes since the early 80s. Also going to discuss life expectancy and end-of-life management, as well as treatment and support of our veterans with dementia. Now, as you know, I've given everyone sent everyone the PowerPoint ahead of time, so you have all of this to go over with me, and also you'll be able to access this recording afterwards. So there are some slides that are very bulky. I'll do my best not to read through them all verbatim, certainly, and if I do tend to gloss over certain things, if there are any questions after the training, then I'm open to all that. So, with that said, some basic information. Dementia, bit my tongue. Dementia is not a diagnosis per se or within itself. It is not one specific disease. The term often describes a decline in neurodegenerative dementias that affect older adults and are severe enough to interfere with the individual's everyday activities. I do have some statistics, always do. In 2022, 4% of adults aged 65 and older reported being told they have dementia by a healthcare provider. That is similar for not only men and women, but there's also no significant differences in those studied that were veterans. The percentage of adults with dementia increased with age. I would expect that, but it's a pretty big change. So from 1.7% in individuals 65 to 74, but then in those age 85 plus, it goes to 13.1%. So that's pretty significant. Previous research estimates that about 10% of the U.S. population age 65 plus has dementia, with a higher prevalence found in residents of residential care facilities, in nursing homes, long-term care facilities, whatever they may call it, but in that type of long-term care. It's severe. Obviously, it's chronic. It affects cognitive functioning, memory, attention, perceptual motor, language, reasoning, social cognition, and it interferes with everyday activities in their personal life. So obviously a big concern. And Alzheimer's is it's the most common subtype of dementia, but of course, doing all the research I did for this, although it is the most common, it's by far the only subtype of dementia, which we'll go over a little bit later. To my surprise, and probably to yours as well, in 2023, so just last year, the cost in the United States to support dementia patients was $345 billion. That's with a B. That is shocking, and that is a number I did not expect. There are some predisposing factors for dementia, and including social and cultural risk factors. Just going to go through a few. So, not staying cognitively active, being female, not treating the health conditions as they arise. So more or less like beginning in their 60s and early 70s, obviously letting things go unchecked, not going to the doctor. Oh, I'm fine, or whatever. That's a cultural factor in a lot of ways. But it could also be a sociocultural factor, which is also listed. Lower socioeconomic attainment, lower educational attainment, any kind of medication interactions, poor quality of sleep, non-restorative sleep. Again, not being active physically, socially, cognitively, not having enough vitamin intake. A predisposition is Down syndrome, which we'll talk about a little bit later, and HIV and TBI. And a big one is not managing cardiovascular risk factors like smoking, poor diet, obesity, anything leading to a vascular disease, because although Alzheimer's is the most common, it's mostly associated with vascular dementia as well. So that's of concern. Young onset, and that's before the age of 65 for the purposes of this presentation. It looks pretty much exactly the same. We're looking at lower socioeconomic status, lower education, being socially isolative, not having good vitamin intake, diabetes, depression, that kind of thing. Two of these are very interesting to me, and not having time in this presentation to, really go through these. No alcohol use, okay, as opposed to the other factor being too much alcohol use. No alcohol use for those under 65. So that's perplexing to me. But also lower hand grip strength. Now, again, I don't know the biology behind that, but I think that's just one of the many factors that, and we'll talk about things to look for later, and when we talk about the different stages of dementia, but lower hand grip strength. And then, of course, any orthostatic hypotension or anything that is vascular related is going to be a risk factor. All right, again, you've got this in your packet, so I'm not going to beleaguer the DSM-5-TR diagnostic criteria. You also have access to this in your DSM-5-TR, so I'm not going to go through all this. I want to talk about it more in regards to the stages. So I think this is what I was talking about, breezing through a few. All right, kind of want to go through these. Oh, I do want to talk about severity and specifiers, though. Much like any other diagnosis, there's mild, moderate, and severe as far as how we're able to rank the diagnosis. Mild is going to see difficulties with instrumental activities of daily living, like housework, managing money, like paying bills and stuff like that. But in the moderate stage, we're going to see difficulties with basic activities of daily life, like feeding themselves, dressing themselves. And then unfortunately in the severe stage, which is oftentimes when it might be too late to reverse some of the effects, something else we'll talk about a little bit later, that's when our veterans are going to be fully dependent. So, with that in mind, we'll talk about some specifiers. Now, you're either going to see behavioral disturbances in our veterans or we're not. Behavioral disturbances are actually quite common. Or, of course, as diagnostics go, it could also be an unspecified. If there's no behavioral disturbance, we don't have enough data yet to make that determination, then it's going to go unspecified, obviously. But a lot of times we're going to see psychotic symptoms, mood disturbances, agitation, and maybe even over things that never ever used to, be a factor to be agitating, and a very apathetic attitude, just really other behavioral symptoms we'll talk about a little bit later, as far as like wandering, different types of aggression, stuff like that we're going to see with the behavioral disturbance specifier of the criteria. Now, I could talk about differential diagnosis all day. That is not my professor's wish for me to do that. So one thing I just want to get really clear through this section of differential diagnosis is the whole point is to go and be very nitpicky, shall we say, about what we're seeing in our veterans, and how do we then specify what the diagnosis is going to be, plus the severity and possibly the specifiers. So it's extremely important, and especially because there's mixed dementia. Again, I was saying that Alzheimer's and vascular dementia are often co-occur. So you really have to get to the bottom of what we're looking at. It can also be, diagnoses can always be complicated by other factors, and that is why it's extremely important to differentiate, which obviously we're talking about. Obviously, no single test can diagnose dementia, so multiple tests are in order. Cognitive and neuropsychological testing, of course, psychiatric exams, including pretty extensive, I would say, mental status exams, neurological examinations, brain scans like the CT, MRI, or the PET, and can even go so far as to do blood tests and spinal fluid testing. So a lot of things, a lot of different tests can help determine where they're at in their diagnosis. It's really important to rule things out. Learn this in differential diagnosis. That's part of it, is the rule outs of depression, delirium, thyroid problems, tumor lesions, untreated sleep apnea, side effects of medications, which we tapped on, and then vitamin deficiencies also, and then metabolic toxicity, which I find very interesting. Again, that's including from alcohol use. So I saw that a lot in my research, that alcohol use is a factor either in, I know, doesn't make sense, helping to prevent or helping to exacerbate. All right, now this is one of those slides where it's in your packet. First of all, it's probably really tiny, but this is the Alzheimer's Association, so very credible as far as differentiating between the common forms of dementia. Excuse me, not every one of them is featured here, obviously, but we're talking about Alzheimer's, vascular dementia, dementia with Lewy body, Parkinson's disease dementia, and frontotemporal dementia, something I also have too much experience with, but probably just need to cut that part. Anyway, so differential diagnosis, you've got this to show you all the differences, and I'm talking its course, its presentation, the associated features of each, and then most common risk factors. So it's all in your packet. Also diagnostic imaging, again, when we're talking about the CT and the PET scans and the MRIs and whatnot. Not MRIs necessarily, yeah. So diagnostic imaging, what we're going to see, the fluid biomarkers to assist in the diagnosis, in the diagnoses, and then just some other things that are comparative. Now again, just the bottom line seems to be knowing what the key clinical symptoms and the pathology of the causes or the etiology of dementia can help professionals to really, again, get to the bottom. Ultimately, what we need is for our veterans to be cared for. Our loved ones must be cared for, and so they can maintain the highest possible quality of life. That is an absolute absolute essential, not only for end of life, but when we're seeing dementia in our vets that are mid-60s, 70s, and then obviously in their 80s and 90s and stuff. No matter what age, we're going to want them to have all the right treatment, support services, and ultimately for them to be able to live their best life. All right, let's talk about etiology, or where does it come from? What is the cause? It's caused by damage or loss of nerve cells and their connections to the brain. It can affect people differently, as we've kind of discussed. And the symptoms really tend to depend on what area of the brain has been damaged or where has the brain been injured. That is the reason also for the brain scans. Again, we talked about some predisposing factors. Having Down syndrome, it just, for whatever reason, again, beyond the scope of this presentation, is a risk factor that just can't be mitigated. It can't be changed. It is what it is, and we're not going to see veterans with Down syndrome, obviously, but when we're talking about our loved ones, or in our veteran families and our military service families, we obviously have members' family with Down syndrome. That is just something to keep in mind. Neurocognitive disorders, or NCDs, are based on definitive cognitive domains, and symptomatic veterans need a complete medical assessment. Again, we talked about having the brain scans and stuff and the psychological testing, but it's extremely important in order to capture the complex attention, the executive function, learning and memory, as well as language, perceptual motor abilities, and their social cognition. It's extremely important for us to either, if it's beyond our scope to do the full medical examination, which it may tend to be, we have to make sure that we're in good coordination with their primary medical physician so that we can make sure that we know exactly what is going on with their diagnostics as far as testing that we do not do. So that's all obviously very important. Now I've got some really good graphics here, and that's kind of why I breezed through the DSM-5-TR diagnostics, because this is just easier. Again, part of the etiology, we're looking at Alzheimer's and we're looking at vascular dementia, but we're actually looking at mixed. And again, that could be the Alzheimer's and the VD, the vascular dementia, or it could be something else. It could be exacerbated by alcohol, excessive use of alcohol, Huntington's disease, traumatic brain injury, as we discussed, Lewy body dementia, as we discussed, excuse me, but also what's not listed here is the frontotemporal degeneration, medication use, HIV infection, also discussed, Creutzfeldt-Jakob disease, Wernicke-Korsakoff syndrome, and normal pressure hydrocephalitis, which I'm actually looking more into. I've got some interest in that. Parkinson's disease, which also isn't listed in the top 7, or the 7 types. What else we got there? And of course, any of the mixed etiologies. Talked again about the Global Degeneration Scale for Assessment of Primary Degenerative Dementia. No, my bad. The Global Deterioration. Did I just say that? Sorry. I'm getting long in the tooth here. The Global Deterioration Scale for Assessment of Primary Degenerative Dementia. Whew, the GDS. Point is, it's been used since, pardon me, its conceptualization in 1982, and it just still continues to be the scale that is used for assessment of dementia. Now, well, you know what, actually, I got a better graphic for this, but it is all derived from the GDS. So they're talking about the mild cognitive decline or mild cognitive impairment, mild dementia. So these are the stages that were established back in 1982 with this GDS. A little bit more modern take on it, with a ton of similarities, obviously, is the 7-stage of dementia scale. I really, pardon me, I particularly like these. It just kind of breaks it down a little bit more, especially for us working with the veterans. Kind of a quick reference. What are we looking at? What stage might they be in? Obviously, this is important for treatment and support and just understanding what our veterans are going through at different stages through the progression of their dementia. Again, we're looking at normal aging being, there's no signs of dementia at all. Very mild cognitive decline. We kind of talked about that. Then we're looking at the early stage of dementia, and that's the mild cognitive decline in stage 3. Early stage dementia is stage 4. And as it kind of relates to the chart right next to it, that's when activities of daily living become affected, like bill paying, cooking, cleaning, traveling, that kind of stuff. Then, obviously in stage 5, it starts to get a lot more serious. That's the moderately severe cognitive decline and the severe cognitive decline in the mid-stage. And at stage 5, we're seeing, they need help dressing, selecting appropriate attire for wherever they're going, or if they're not going anywhere. And then, of course, we're looking at that moderately severe dementia, needing help putting on clothing, bathing, needing help with toileting and things of that sort. Definitely in stage 6, it's looking more severe with the urinary incontinence. So that's going to be a lot more services needed for that stage. Fecal incontinence comes shortly thereafter, and then into stage 7, which is considered late stage dementia, and that is everything from not really being able to speak full phrases at this point, and maybe 5 to 6 words a day, and then on into, I do like how this one breaks into 7A, B, C, D, E, and F, and this is the only one that I saw that did that, so I find that very interesting. 7B speaks only one word clearly. 7C can no longer walk. 7D can no longer sit up by themselves or being propped up. And then 7Es can no longer smile, so they lose control of, I don't know if they lose control of their muscles or if their brain just doesn't talk to them anymore. Like I said, that's kind of beyond the scope of this, but I've got some personal reasons to ponder these things. So anyway, in 7F stage is they can't hold their head up anymore, and a lot of different scales also, that's the terminal stage. All right. So again, this is what we just went over. Yeah, I like this one too. So let me see if there's anything different here. Yeah, actually, I do. I want to talk about the mild cognitive decline in stage 3. This is, I think, what is associated a lot in a stigmatizing way with older folks with dementia, is the getting lost and just can't, like, losing things, have a hard time concentrating. That's when you start to see kind of that difficulty in social settings, maybe as some isolation and stuff like that. And if they are still working at that point, that's when, what I've read, that's when their coworkers are actually a lot of times saying, we're seeing some challenges, or this is when the ball starts getting rolled, because this is, if they're still working, this is when some of that early cognitive decline can be detected. So that's one that I wanted to point out. So that stage 3 is kind of where we're getting to see what's really going on. And now here in the stage 5, moderately severe cognitive decline, they talk about at this stage forward, so stage 5 through all the way through stage 7, this is where they need assistance. They can't function independently anymore, and unfortunately this is a lot of times where we see them going into long-term care facilities, which, as we've learned, can actually exacerbate the dementia symptoms, and that's for a myriad of reasons. Of course, stage 6, looking at severe cognitive decline, and this is what I was talking about before, this very severe cognitive decline. This is when, I'm actually going to read this one. So, in the final stage, the brain appears to lose its connection to the body and becomes incapable of telling it what to do. Motor skills, ability to speak are lost, unintelligible words or phrases, all personal care has to be assisted, and walking, again, total incontinence, cannot sit up or hold their head up anymore, and they don't smile, and their muscles appear rigid at that point. And of course, at this stage, it's terminal. So, it says here, one of the most common causes of death in end-stage dementia is pneumonia or a lung infection. So if you've got somebody that has COPD, that's already an increased risk, but that's actually when pneumonia develops is what could actually end their life. So, and this stage, in all fairness, can last from weeks to years. Just kind of depends on where the progression was caught. All right. So, before we get to the good stuff, let's talk about, again, some life expectancy. Obviously the time or the age of diagnosis, how severe it was, how far had the dementia advanced by the time it was detected, diagnosed, what type of dementia is it? Is it Alzheimer's? The life expectancy, if they are diagnosed in their 60s or 70s, their life expectancy is about 7 to 10 years after diagnosis. But for an individual with vascular dementia or Lewy body dementia, life expectancy is about 5 to 7 years after the diagnosis. So again, it just depends. Each dementia is affecting the body and the brain differently. So that's an explanation as to that, a very layman explanation as to that. And then, of course, presence of other conditions. What else is our loved one dealing with? What else is our vet dealing with? Also, is there cardiovascular disease, diabetes? What about stroke? Any of those things can shorten the life expectancy. 10 signs death is near in individuals with dementia. There's more infections. They experience more medical complications. They move around less. Again, their ability is thwarted a bit on that, so they're unable to move without help. They become very frail. They may fall, break their hip, an arm, an elbow, anything that lands first, essentially. They have problem eating and drinking, so their nutritional, they're not taking in as many nutrients as they need, and a lot of that is because they can't swallow. Maybe time for a feeding tube, something like that. I read that a lot of dementia patients refuse feeding tube, which obviously can exacerbate their the progression and their life. It can diminish their life expectancy. They have they're not able to speak. It's difficult to know exactly what they need. Of course, if you've worked with them for a long time, or you're their loved one, their partner, more power to you as a caregiver. But this is when it's very difficult when they are not speaking at all. It's very clear that the end is near. Lack of facial expressions, things of that sort, keep a very dull eye effect, and they're sleeping a lot. You notice that they're sleeping. Right before death, we're looking at days, maybe even hours before it's the deterioration of the person, the individual, our loved one, is clearly diminishing. They absolutely lose the ability to swallow. Their hands and their feet become very cold, and they lose consciousness. So, and a lot of times it's very irregular breathing and with a rattly breath. That's how you know the end is quite near, anywhere from hours to days. All right. Whew, had to get out of that. So, more on the plus side here. Treatment support. There are some things that we can do even after somebody has been diagnosed with dementia. Or if they're showing signs but haven't advanced to the point where, so they're in stage 1, essentially. Some causes of dementia-like symptoms can be reversed. I think this is really important for us to keep in mind that, and of course, all of the testing we talked about before, this is why it is so important, because some of this can be reversed with treatment. That's including infections or immune disorders, metabolic or endocrine problems, low levels of certain nutrients. Again, we've talked about vitamins and vitamin deficiency, subdural bleeding, brain tumors, and normal pressure hydrocephalitis. Hydrocephalus. Got it. Anyway, and I think it's really important that the Mayo Clinic pointed out that this identification of and treating patients with neurocognitive disorders of all kinds, it needs to be a public health priority. Now that it has affected my life personally, I cannot be in more solid agreement with that. It has got to be a public health priority. And obviously, I think prevention is extremely key, and helping our veterans so that it doesn't progress. So there are also some ways that we can, from studies, empirical evidence has showed us that there are some modifiable risk factors. Thank goodness, right? That can either decrease the risk of developing the dementia or of accelerating the dementia. A lot of times this is what we're looking at. The dementia diagnosis, a lot of the symptoms are already clear. What can we do to stop it or to cease its rate of acceleration? Okay, so I did a bunch of research on this, and what makes sense is a lot of cognitive stuff. Reading, puzzles, word finds, coloring, learning something new, building something tactile, staying socially active, maintaining good connections with family and friends. We definitely want to keep them in the fold. Keep them around familiar faces, keep them around, well, we'll talk about that here in a minute. Anyway, and what I found really interesting, and because I love Mediterranean food, a lot of research is done on after Mediterranean food needs to be consumed as much as possible. I went ahead and put a little thing on there for your reference as far as what different kinds of foods, but that is really, really good to know, especially with somebody with family members that are going through this right now. It's really good to know. And even people that don't have diabetes, which I don't even know who in the world isn't pre-diabetic at this point, but even if somebody is not diabetic, and the Mediterranean diet will help them do this, is keep that blood sugar low, in check, managed. As a type 1 diabetic, I can tell you, it's no fun. So if you're pre-diabetic, word to the wise, take care of it. All right. Now, this is extremely important in any kind of support, but we've got to get a multidisciplinary team around our veterans. They've got to get involved in supportive services, whatever that may be, if it's from the VA, some other work-based disability, something like that, government, whatever it is, we've got to get those support services in place. Also using mindfulness and trying to get them into a deep calm for stress reduction. Yoga, obviously adorable pictures here on this slide of older folks just being active, and they're with other people. They're being social. They're being supported. Specifically aerobic exercise. So that's why I put that on there. But yoga, at least some mindfulness exercises, guided meditation, relaxation, deep body, all that kind of stuff is really, really great. And then obviously getting adequate and restorative sleep. We could say that for every stage in our life. But at this point, and along with the physical exertion, I think good sleep is kind of in the cards there. All right, so to end out, I want to talk about paying attention. Like, what are we looking for? We have to help them follow a healthy lifestyle and live one along with them, right? Diet, exercise, lowering cardiovascular risk factors, like we said, was a predisposer. Obesity, high blood pressure, if they're smoking, get that out of their mouth. High cholesterol, of course, diabetes is a precursor to a lot of different things. But in these next few slides, I just want to really enunciate the fact that we need to pay attention to our loved ones. Are they drinking too much? We've discussed that AUDs have been linked to not only early onset dementia, but an acceleration of dementia. Are you noticing that they're not hearing very well? Are they not seeing very well? Is this something that is not being communicated? More importantly, can you tell that they're not seeing or hearing very well, but they're not reporting that to you? That's going to be a concern. We talked about the etiology and the predisposing factors. Are they neglecting their physical and their mental health? As they pop up, again, predisposing factors. It's also a cultural factor. A lot of people, a lot of men and a lot of women, they don't want to go to the doctor for a lot of different reasons, or veterans, they aren't wanting to go to the VA, but they don't have an alternative PCP. There's a lot of things wrapped up in that. But if you're noticing like they haven't been to the doctor in a while, or they stop going to the doctor after a certain amount of time, then we need to make sure that they're not neglecting that physical and mental health, those factors in their lives. Do they seem depressed? Do they appear depressed, or are they even making the word, I'm depressed, I'm not feeling like myself, I'm not doing well today, I don't feel right, I'm down, I'm going to stay in bed, whatever it is. Let's pay attention. That's an indication. And also, are they sitting and watching TV all day? Now, of course, this can also be linked to the depression, but if they're sitting around not having their mind stimulated, what we talked about before with reading or card games or puzzles or art projects or building something new like a birdhouse or a dollhouse for their kiddos or their grandkids or whatever. Or if they're being isolative and they're not wanting to participate in things that they've usually participated in, but even activities that are more focused on them. If they're like, no, I'm good, or they don't have a response or something like that, that isolation needs to be a concern and something that we need to, not just pay attention to, but take matters into our own hands and help them out. Again, are they avoiding social events, things that they normally attended? How is their sleep? Sleep apnea, like we talked about, can increase the risk of developing dementia or exacerbating once it's already been diagnosed. Sleep aids such as Benadryl can actually worsen memory, so something really good to keep in mind. Do they take their vitamins every day? And I think, honestly, for our loved ones, once they're in their 60s, 70s, I think gentle reminders to keep up on taking whatever vitamins their prescriber suggests for them. That's extremely important. Low levels of vitamin D, B6, and B12, folate can increase the risk of dementia or, again, exacerbate that risk once it's already been established. Do they live in an area that is full of air pollution? Do they live in the city? Do they live near trains? Are they in a portion of town where there's a ton of traffic? Or are they outside, are they in an area? My best suggestion, and what I would love to do with my loved ones, is take them to the mountains. Get them up and out of that urban jungle, that concrete jungle, and away from the exhaust. And also in the interior of the home, make sure that they've got or their room, or whatever the case may be, that they have air purifiers, and plenty of them. Just as much pure air as they can ingest, the better. So that's something, I love the idea of getting older folks up to the mountains, and a lot of times that's going to spark memories, and that's a good thing. Managing end of life. Kind of talked about this. I just want to breeze through this. So while advanced dementia has no cure, we talked about that. It's chronic, progressive, ultimately leads to death. You can still help them by providing comfort, playing an active role in their care, again, paying attention, and making sure you spend time with them, playing cards, taking them over to the mountains, playing cards in the mountains. How amazing would that be? And of course, there's memory care units, skilled nursing facilities, hospice, stuff like that. And of course, depending on the stage of dementia someone is in, they may absolutely need to go into that long-term care or the final stage care. Again, it's just going to depend on the loved one. The differences are, there's memory care units, there's hospice, and that's often when that's the final stage. So I don't want to beleaguer that too much. I thank you very much for your participation. If you have any questions, please let me know. The GDS is in your packet if you want to utilize that, or like I said, that can be looked up in the reference pages. So thank you very, very much. I appreciate it. And let me just show you real quick before I sign out. My reference page 2, and the GDS pretty much, well, in its entirety, just broken into 2 pieces in case you want to use it. So again, thank you so much. I appreciate your attention. Have a good one.